First of all, let me thank the organizer for inviting me. This is my second venture in this nephrology group as a cardiothoracic surgeon. A few years back, I was invited to talk on role of a cardiovascular and thoracic surgeons in kidney diseases. Today it is slightly different topic. So I divided my talk into three zones: overview, principles, and techniques. When you are doing a vascular anastomosis, there are certain requirements, prerequisites, and these are mandatory. You cannot skip them. First and most important is the good instruments. Now, all of you buy cars, all of you buy gadgets. Before buying, you will go through their features, what are the options in the market, and you are ready to pay extra money to get those features. As soon as you buy that gadget or car and bring it home, there is a depreciation, 15 to 20% drop in its price, and still you buy it. The instruments is the same thing. Invest in the instruments. Here there is no depreciation, it is going to be appreciated because you are going to do more and more AV fistula, and probably your AV fistulas will be more functioning and long lasting if you use proper instruments. These are the simple instruments used for the vascular surgery. I've seen surgeons, I've seen nephrologists using crude instruments which are not supposed to be used for the vascular surgery. They are supposed to be used for orthopedic or general surgery. I think that's not a good thing because the results will be compromised and you don't want the results to be compromised. That's the most important bottom line. Good light. Again, there is no excuse for that. How will you see a small vessel? Just Dr. Sonali said 2 millimeters and 3 millimeters. I've seen somebody doing AV fistula under a torch. I think it's just impossible. You can't see it. And believe me, I've seen it. 34 years experience. I've seen it. So you should have good lighting. Unless you have good lighting, how will you see? It's an operation. You can't do it on bedside. You can't do it somewhere. You can't do at available place in a corner. You have to do it in operation theatre. Dr. Babikar has already explained you what are the possible likely complications and problems. Again, enough experience to see them and sort them out. Anybody's hand, they can happen. Even after 34 years, I still do those problems. So, always do it in a OT, in a sterile condition. It's an operation. No excuse for a magnifying glasses. Everybody wants to do it, but most of them don't want to buy magnifying glasses. You cannot do vascular surgery. It's a vascular surgery. You cannot do vascular surgery without magnification. 2 millimeter vessel, 3 millimeter, at the most 4 millimeters. How will you see? Whatever good eyesight you might have, but when you take stitches, you are not likely to see them properly. So always you don't have to buy a very expensive loops which a cardiac surgeon probably buys. You can have simple, not very expensive loops, but have them. You don't need a microscope. In my opinion, you need a magnifying loop which is 2.5x. You don't need 4.5, you don't need 6. I myself, a cardiac surgeon, my main work is coronary artery surgery, and I use 2.5. If that is good enough for coronary artery, I'm sure it is good enough for vascular. And you don't need a loop which is 3 lakh rupees expensive. Buy one of the cheapest, but always buy it. Coming to the principles, there are some principles in vascular surgery. Good exposure. To have good exposure, first thing you have to know is anatomy. So learn your anatomy before you venture into any surgical branch. And doing AV fistula is a surgical branch. So learn anatomy. Previous two speakers have already given enough coverage on anatomy, but do read, do find out what are the variations in the arteries, what are the variations in the veins. You don't want any surprises on table. So good exposure. I've seen people doing exposing the arteries with very oblique or transverse or funny-shaped incisions. Avoid all those things. Use vertical incisions for the radial and use a transverse incision for the brachial. They are the best ones because they will heal good. and you will have list of the scar related problems. Sharp dissection. As a surgeon, I always been telling all my juniors and trainees, the surgeons never use mosquito or artery forceps for dissection. If you are a surgeon, use scissors or a cautery. It is a fear. It is a fear in the mind that if they use cautery or scissor, they'll cut something. But let me tell you, if you use mosquito or artery forceps, you will not tear, but disrupt and destroy the vessels. You will destroy the tissues, and you don't want destruction of the tissues. So, nice, clean, fine dissection. And to do nice, clean, fine dissection, again back to the first one, you have to know your anatomy. Handle tissues and vessels very carefully. You cannot be rough and use proper instruments. You cannot use crude instruments, crude big forceps. You have to use micro forceps. You have to have fine tip forceps and fine tip scissors, fine tip arteries to do AV fistulae. It's a surgery. It's a surgery. It's not medicine. It's surgery. Let me re-emphasize again and again. You have to use proper instrument. If you are clamping your vessels, use bulldogs or the vascular clamps. Well, if you don't have, you can use slings. But let me tell you, slings are not cheap. You should not be using any sling. If you want to use, as we use, then they are called silastic slings. And silastic slings are very expensive. Instead of that, you can spend the same amount of money in metal bulldogs and they will last you all your life. Silastic sling probably will last you for 6 months or maybe at the most 1 year. You should have different types of bulldogs and different types of vascular clamps if you are planning to do AV fistulas. I know all of you don't do heparin. I am a vascular surgeon and this is what I will always recommend. I have been doing since 1988. We have to give heparin. I know nephrology enough. Your patients have problem with the clotting. The clotting is deranged. That also I know. But still, in the principles of vascular surgery, you have to give heparin. If it's a big adult, usually I give single dose of 5,000 unit IV. If it's a medium sized adult, I'll give 2,500 units single dose IV. But you have to give. The second thing is make heparin saline infusion. 1,000 unit of heparin in 100 ml normal saline, get in the syringe. The vein you are going to use for anastomosis, put a 20 angiocath in that and flush that vein with that heparinized saline. Maybe 10, 20, 30 ml, whatever you want, which is appropriate for your patient. That will flush your vein, number one. That will line the vein with the heparinized saline. So when you are doing the anastomosis, when there is no flow, the chance of a clotting in that vein is reduced. So if you are not using heparin, you must start using heparin. This is a fear again in your mind that if I use heparin, they will bleed post-operatively. No, they don't. Take it from me. Every patient I give heparin, which will stop their bleeding completely until they don't bleed. Sutures. The commonest suture or the only suture we should be using is polypropylene, or common name is Prolene. That's it from J&J, but there are different companies which will have different trade names, but basically it is polypropylene. Commonest you should be using is 6-0 Prolene. That is the best. I don't think you should be using any bigger than that. You don't need to use even smaller than that. 6-0, you can use whatever comfortable needle, 8 mm, 10 mm, 11 mm, different needles are available. You can choose and pick, but 6-0 Prolene is the best for any anastomosis, whether it's a radial or a brachial, end to side to side, any type. Don't use silk. I've seen silk being used. Silk is no. Seen people using catgut. I think he doesn't know anything about surgery if they start using catgut. Okay. Last thing is the technique. Already covered different types of anastomosis. I grouped them into two different ways. One is artery to artery. The second is vein to vein, artery to vein, and vein to artery. As a nephrologist, you don't do first two, but you do last two, artery to vein and vein to artery. And they can be grouped again into this, which already has been covered. It's end to end, end to side and side to side. It is just technicalities, the basic principles, techniques, precautions, everything remains the same. When you are suturing, you have two vessels. In your specialty, you have an artery and one vein. Always, 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 always go inside out on the artery. That's the safest. As Madam already said, that there will be arteries which are diseased, maybe soft atheroma, hard atheromas. If you could go outside in, you are likely to disrupt that atheroma, and you are not an expert vascular surgeon to deal with it. So, for your specialty, it is always all sutures on the artery inside out. If you are an expert vascular surgeon, you can do inside out, outside in, doesn't matter. On the vein, it is always done outside in. So vein outside in, artery inside out. Remember that. When you are taking a stitch, always take all three layers: adventitia, media, and intima. If you don't do that, there is likely chance of bleeding, and the worst complication, that is pseudoaneurysm. Pseudoaneurysm usually happens if you have not taken all the three layers. Can anybody tell me of the three layers, adventitia, media, and intima, which is the most important? Is the intima. Okay. Why? Because intima is the one which is going to be lining the two vessels, intima to intima. And if you don't do it properly, then there is a leak. The strength in these three layers is in intima. It is wrong that media has a strength. No, it is the intima. Thrombosis will happen only if the intima is not properly matched. So intima is the most important of the three layers. When you are doing surgery, don't do something like this. Okay. Always stabilize your hand, support, keep somewhere. Your movement should be only in the wrist, not in the elbows. If you use your elbows for this type of anastomosis, you are going to put a lot of pressures, number one. Number two, there will be a lot of movement. So precision will go away. So all the movements have to be at the wrist. Just 34 years experience, I have put it on some pictures. Before that, when you are passing the needle, make sure that you pass the needle at right angle to the vessel wall, not anything. It has to go at right angle to the vessel wall. If you don't, then you are likely to cut through the artery, number one. Number two, there will be some what is called dog ear, which will leak or bleed. And number three, your anastomosis at the end of construction will look awkward. The anastomosis at the end should look what is called cobra head. It should look like this. If it doesn't look like this, that means you have not done it properly. I've seen people mounting the needles, not just nephrologists, but vascular surgeons, cardiac surgeons as well, as they wish, like this. They hold the needle at the end of the hold at the end of the needle. This is how people hold as well. With the center, correct. They are nearly there, but it should be like this. It should be. You should hold the needle in the middle, and it should be forward angulated 45 degrees. Those who are already doing it, please try this technique next time you are doing a fistula, and you will see the difference. It becomes so easy if you mount it forward. Okay, occasionally we do mount it other way around, but you don't need to that. That is reverse 45. It is angled opposite direction 45, but for you that is not required. So this is the way every stitch, every needle you should be mounting. Halfway through, forward mounted 45 degrees. The arteriotomies can be done in different ways. It can be longitudinal, it can be transverse, and it can be oblique. But again, in your specialty, you are always going to do what is called longitudinal arteriotomy. That means cut along the length of the artery. Never please cut artery transverse. You will not be able to do anastomosis with a transverse cut or even oblique cut. So longitudinal arteriotomy has to be done. So how much? The recommended is about 4 to 6 millimeters. So you don't have to have a very big arteriotomy. Occasionally you will find that your wrist or the elbow vein is very big. And then if you want to do end-to side anastomosis, you might have to increase the arteriotomy size a little bit to adjust the foot. But average is 4 to 6 millimeter. Another point which I want to make is I've seen people dissecting the radial artery and brachial artery full length all around. It becomes like this, free vessel. Don't do it, you don't need to. You need only the top surface where you are going to do anastomosis. Why do you want to dissect the undersurface? Why do you want to do the side effect? So I am told that we have been taught like this. Okay. When I ask them, their teacher, they say we have been taught like this. But this is not the way you have to treat, you have to do. You have to only dissect the top surface. Okay. Then this is the artery, suppose you are dissected already. Now you'll ask me how will I put the bulldog or a clamp. Okay. Use your instrument just to go around here, go around here. If you have slings, put the slings. You can lift the slings, you have bulldog, just clamp it, clamp it. And people also say that then we find small branches in the middle bleeding. Let them bleed, they are not coming in your way. Use a small suction or saline syringe to flush it out, and you don't need to dissect. If you dissect it too much, number one, artery goes into spasm. Number two, you are likely to injure the branches, you are likely to injure the nerves. And if something goes wrong, then you are stuck. Continuous or interrupted sutures, this is a debate. All anastomosis to be done by continuous sutures. Interrupted sutures are done only by the plastic surgeons, that is under microscope. We can't do interrupted sutures. That is for 1 millimeter and below vessels. And we hardly do 1 millimeter anastomosis. Never touch the intima. I've seen people touching the intima, lifting the veins, lifting the arteries and touching the intima. I just told you, intima is the most important. As soon as you pick up with the forceps, it is injured. Injured intima is a site for a thrombus formation, for Chau's triad. And then you wonder why my anastomosis is not working, why my anastomosis have failed, why it has not matured. Because you have touched the intima. Don't touch the intima. There is a lot of adventitia to the vein, adventitia to the artery. Use it. It is free. You can use as much as, you can hold as much as you want, but don't touch intima. Complete the far side. What does far side means? If I am sitting here or standing here and do the anastomosis, try to do this layer first and this here. Why? Well, you see it easier at your side. If you do it on that side, it becomes difficult to see. So always do far side first, suturing like this and finish here. So start from here, go around and come back. When you are using proline, you can have 3-4 knots, at least 10 knots. Because otherwise it will not slip. Always make sure that the knots are outside the anastomosis. I see people putting the knots inside and say, कुछ नहीं होता वो हो जाएगा ठीक, बड़ा vein है. अरे, it is not supposed to be inside. It has to be outside, and it has to be blood tight. That means when you remove the clamps, the blood should not come out. If the blood doesn't come out, then it will not bleed afterwards. If the blood is coming out and if there is a dog here or there is a gap between the 2 stitches, just put extra stitch and stop that bleeding. Just few points to take home. There is no one way to do something. That what I am telling is not the only way, but these are the basic principles. You can do your own. You can learn from your colleagues in your hospital, vascular surgeons. Learn as many techniques as possible. But make sure you are comfortable with one. And which is useful to you, keep using it. But you should know other techniques because sometimes you might be finding it difficult, and if you know the technique, it can be helpful. Practice makes perfect, there is no shortcut. I don't need to explain on that. Keep doing fistulas, you will get better. Observe, learn, improve and improvise. Go and see vascular surgeon, go and see your colleague nephrology, go and see your urologist, see how they do. Is there a difference? Can I improvise? Can I get it better? And don't do corner cuttings. If you start corner cuttings, you are likely to have complications. All sort of complications. All sort of. I have seen people using one suture for 10 patients. Can you believe it? It's not fair. It's not fair. You charge 10,000 rupees and proline is 500 rupees. It's not fair. It's cutting the corners. Infections. And don't hesitate to call for the help if you are in trouble. Nobody is going to say anything if you call for help. I'm sure your vascular surgeon or even colleague nephrologist, experienced urologist will come and help you in this. Before we end, I'll be happy to answer any questions if there are any.